All right, let's talk about immunohistochemistry. If you're in pathology, you know it is absolutely central to what we do every single day. Today, we're going to dive deep into the brand new 2024 CAP guideline update for validating these assays. Think of this as your official playbook for making sure every stain is spot on.
So, let's start with a situation you'll see all the time. A new antibody shows up at the lab. It might be for a simple diagnostic marker, or it could be a game-changing predictive marker that's going to guide a patient's entire treatment plan. You can't just, pop it on the stainer and hope for the best. There's a whole process, a rigorous one, to make sure that antibody is accurate and reliable. So, let's walk through what you need to do to get that new reagent from the shipping box to a patient's slide.
Here's how we're going to break it all down. First, we'll cover the foundation, the why behind all this. Then, we'll get to the new golden rule, 90% concordance. After that, we'll talk numbers, how many cases you actually need. We'll even cover some special plays for those tricky specimens. And we'll wrap it up with game maintenance, which is all about when you need to revalidate.
Okay, first up, let's lay the groundwork. Why do we even do this? It's not just about ticking boxes or doing good science. It really comes down to patient safety and, honestly, the law.
Yeah, let's be super clear about this. This isn't a suggestion. It's not a best practice. It is a federal requirement under CLIA 88. Every single lab has to prove its test work the way they're supposed to before they're ever used to make a clinical decision. This is the absolute bedrock that protects our patients from bad results. Now, here's a really critical distinction, especially if you're a trainee. You need to know the difference between validation and verification. If your lab is cooking up its own test from scratch, what we call a laboratory-developed test, or LDT, you have to do a full-blown validation. But if you're just using an off-the-shelf FDA-approved kit without changing anything, you're just verifying that it works in your hands the way the company says it does. It's a subtle but really important difference.
All right, let's get to the main event. This is probably the single most important number to come out of this entire 2024 update. If you forget everything else, remember this.
90%. That's it. That's the new benchmark. For any test you're bringing on board, your lab has to show at least 90% overall concordance between your new assay and whatever you're comparing it to. That is the target. That's how you know you've passed.
So you might be wondering, what exactly is concordance? Well, the guideline uses that word for a very specific reason. See, for most IHC stains, there's no such thing as a perfect, 100% correct, gold standard test to compare against. So instead, we measure concordance. How well do the results from our new test match up with a comparator? And that comparator could be an old test from your lab, or maybe a result from a different method, like FISH. It's our best stand-in for accuracy.
And this is a really big deal. This is one of the best changes in the 2024 update. It used to be that different predictive markers had slightly different rules and thresholds. It was kind of confusing. Now, the new guideline just simplifies everything. It harmonizes the requirement. So whether you're talking about ER, PR, or HER2, the target is the same, 90%. So much more straightforward.
Okay, so we've got our target, 90% concordance. But how do we actually prove that we hit it? Well, that leaves us to the most practical question of all. How many cases, how many tissue samples do we really need to run? This table from the guideline makes it pretty clear. For a standard non-predictive LDT, like a basic diagnostic marker, you need at least 10 positives and 10 negatives. But look what happens with predictive markers. The bar gets a lot higher. Because those results are going to directly impact a patient's therapy, you need more data. So for both LDTs and FDA-approved predictive tests, you need a minimum of 20 positive and 20 negative cases. It's all about having more confidence in the result. And the rules can get even more specific, especially for complex markers. Think about something like PD-L1 or HER2. The way you score HER2 in breast cancer is totally different from how you score it in gastric cancer. The guideline is very explicit here. You have to validate each one of those unique combinations separately. Every assay, for every scoring system you use clinically, needs its own validation.
Now, the guidelines are smart. They know that sometimes, especially with rare diseases, finding 40 cases is just not going to happen. So, they build in some flexibility. The lab medical director can decide to use fewer cases, but, and this is the important part, they have to write down why. There needs to be a clear, documented rationale for that decision. It's about being practical, but still being accountable. Okay, so everything we've talked about so far has been for our standard, run-of-the-mill, formal infix tissues. But what about the weird stuff? What happens when you're dealing with cytology specimens or decalcified tissues? The guidelines have rules for those too.
Here's the bottom line. If your cytology sample isn't fixed and processed in the exact same way as your other tissues, it needs its own separate validation for every single antibody. It makes sense, right? Different fixatives, like alcohol, can totally change the antigens. An assay that works perfectly on formalin-fixed tissue might completely fail on an alcohol-fixed cell block. You gotta prove it works for each prep type.
So for these special cytology validations, how many cases do you need? The guideline lays out a two-step approach. The baseline is 10 positive and 10 negative cases. But if it's a predictive marker, the stakes are a lot higher, right? So the lab director should really think about bumping that number up, maybe closer to the 20 and 20 standard. And, of course, document everything.
And it's the same exact principle for decalcified tissues, like bone marrow biopsies. The acids used in decalcification can be really harsh. They can destroy the epitopes your antibodies are trying to find. So if your lab works with these specimens a lot, it's on you to prove that your key markers still work reliably after that process.
Okay, we're in the home stretch. Finally. You have to remember that validation isn't something you do once and then forget about. Your lab, your reagents, they're always changing. So let's talk about the rules for when you need to recheck an assay to make sure it's still performing the way it should. Let's start with a minor change, something that happens all the time. You finish one bottle of antibody and you open a new lot of the exact same one. The guideline says a simple check will do. Just run one known positive and one known negative case. It's a quick way to make sure there isn't some weird variation between lots that's throwing things off.
Now, what about a moderate change? This is when you're actually messing with the protocol. Maybe you change the antibody dilution, or you switch vendors, but for the same clone, or you tweak your incubation times. Since you've changed the method, the check needs to be a little more robust. 2 positive and 2 negative cases, minimum.
And then we have the major changes. The classic example here is switching to a completely different antibody clone. This is a big deal. Even if it targets the same protein, a new clone is a whole different reagent. It could have totally different characteristics. For this, the guideline is crystal clear. You have to start from scratch. You have to do a full revalidation, just like you did when you first brought the test in.
So when you boil it all down, the big takeaway from this new guideline is that you need a solid, well-documented playbook. From that very first validation to all the ongoing maintenance, these rules are here to make sure every single IHC result that leaves your lab is accurate, it's reproducible, and most importantly, it's reliable for taking care of patients. The only question left is your playbook ready?